Good afternoon and welcome. My name is Tim Poe. I'm the Director of Telehealth with the UNC Cancer Network, and we are very pleased to have you here today. Thank you so much for being here. A few preliminaries and then we want to get started with our lecture and our guest today. So first off, if you're having any technical difficulties, 919-445-1000, please call us right away. This is our RN and Allied Health Lecture, August 8th, 2018. You can find us on the web at unccn.org. We're on Facebook, we're on Twitter, we're on YouTube, lots of places that you can find out about us. We will be using Poll Everywhere today, and so there are two ways that you can join us via Poll Everywhere. Throughout the lecture today, there will be questions asked, and we would love it if you can respond to those questions. And the way you do that, you can either go to a web browser and just go to pollev, pollev.com/UNCCN, and as the questions come up, you'll be able to answer them on any web browser. A lot of our participants join us via any phone with texting capability, and to do that, you'll go to, you'll text the number 22333 with the message UNCCN. You only need to do that once. Your phone will indicate, you'll get a message back saying that you've joined the session, and then after that you can just go ahead and put in the letters of the various responses, multiple choice responses, and then at the end you'll be able to submit your questions. So we've got an easy one here for you at the beginning. The number of cancer survivors in the U.S. is, and if you think that is increasing, you'll put A. If you think that's decreasing, B, and staying the same, C. And we'll take a look at the answer to that in just a moment. So again, A increasing, B decreasing, or staying the same, C. And that gives you a chance to make sure that you've joined that correctly. Our presenter today is Deborah K. Mayer, PhD, RN, AOCN, and FAAN, and she is an advanced practice oncology nurse who has consulted with organizations on issues to improve cancer care and has 40 years of cancer nursing experience, education, research, and management experience, nursing practice, education, research, and management experience. Dr. Mayer is a member of the Adult and Geriatric Health Division in the School of Nursing and the UNC Lineberger Director of Cancer Survivorship. Her program of research focuses on issues facing cancer survivors and improving cancer care. She has a clinical practice working with breast cancer survivors. Dr. Mayer also is the only nurse on the was the only nurse on the Cancer Moonshots Blue Ribbon panel. So without further ado, Dr. Mayer, welcome. So glad to have you here today. And I might add that you were recently appointed the UNC School of Nursing Francis Hill Fox Distinguished Professor. So as of July 1st, so congratulations on that.
It's lovely.
Absolutely. Well, I know you have a lot to talk about survivorship today, so without further ado, let me go ahead and turn over the controls to you. Let's take a look and see if we have any answers. So again, the number of cancer survivors in the U.S. is increasing, decreasing B, or staying the same, C.
So everybody's got it right.
So, all right,
yeah, so
all right.
Good start.
Good start.
Thank you.
Absolutely.
Thank you. So I'm going to talk about a number of things related to survivorship care, but I know a lot of people are interested in survivorship care plans and the Commission on Cancer's Standard 3.3. And I'm going to weave that through today, but it's not going, sorry. But I'm going to ask you some questions first. Standard 3.3, the question is it a requirement of the American College of Surgeons Commission on Cancer, or is it a requirement of the Joint Commission, or a requirement to be able to conduct clinical trials with NCI? Well, that was fast. You got that right. Let's see. Good. It is a requirement if you are a Commission on Cancer accredited cancer program. It is not required by those other areas. But to get accredited by the American College of Surgeons, you need to meet the standard, which is related to survivorship care and survivorship care planning, and we'll go into that. The next question I have for you is, have you ever developed or delivered a survivorship care plan? So see how many of you in the audience have had experience already. A is yes and B is no. Good. So some of you have had some experience and some of you have not. And I would assume that you're here because you're interested in learning about them and maybe asked to do them. So we'll get into some of that. So what I'm going to talk to first of all, though, is to talk about survivorship trends over time, define cancer survivor and survivorship issues, because a lot of people get hung up on the definition, and we'll talk about who's a survivor and who may not be. Identify what their needs are across time and the continuum, because the Commission on Cancer is broadening their standard, that it's going to be looking at how do we match our services with the unmet needs of survivors. It's not just about delivering a care plan, and to talk then more specifically about a care planning process. But I like to start out with numbers. I'm one of those people who likes those t-shirts that says you are here. And the other thing I want to point out is a lot of the artwork I'll be using today is from Lilly Oncology on Canvas in collaboration with the National Coalition for Cancer Survivorship. You can go online and look at their artwork. They have a contest every 2 years that you can enter artwork as a patient or survivor, a caregiver, or a clinician or health professional. And so this one's called More Than a Statistic, but we will be going through some statistics. So one of the biggest factors we know that contributes to getting cancer, although it's not 100%, most people, it's an aging process. And the older we get, the more hits we've taken in exposures, and we know that we're seeing the baby boomers come through, so that 70% of the cancer trends we're seeing are related just to the aging population. And actually, the U.S. population will be over 65, the majority by 2050. Well, not the majority, about 20%. But for the U.S., a large number of cancer survivors will be over 65, since it is a disease of aging. We also know that we have a growing population of minorities in the country, and so that's going to get more of the mix as well. So we'll see increasing numbers of Hispanic and African Americans and Native Americans and Asians getting cancer. So this year we have 1.7 million new cancers, and that's going to increase over the next few years. But it's not the number of new cases that's really driving all of this. Well, what's driving all of this is the number of people who are doing well with cancer and with their treatment. So you can see this big curve. We are right here where this black line is. We've been seeing this coming for quite a while. And one of the things I think is we know the number's increasing, but we really haven't changed how we practice or how we take care of survivors very much. And that's the thing that needs to change over time to manage this. And that we know that this is going to increase. It's going to be 20 million instead of 15.5 million cancer survivors in the next couple of years. So here we are, we're at about 15.5 million survivors. It's going to go up to over 26 by 2040. And 73% of all cancer survivors are going to be 65 or over. So if you're not practicing gerontology and you're in oncology, take some CE or get ready for that, because you are going to be needing to understand taking care of older people with cancer and all the associated special needs and issues of people with multiple comorbidities, because that's happening. We also know that the number of survivors are highest in the female breast cancer and male prostate cancer, and then some colorectal and some GYN cancers. So that's the largest bulk. I'm hoping that when we do future pie charts like this, we'll start seeing diseases like lung cancer and pancreatic cancer. As we start really improving care, we'll start seeing that in the number of people living with these issues. For example, in the next month, I think there's going to be a lung cancer survivorship conference. And 10 years ago or 15 years ago, that wouldn't have been possible. The other thing to note on this chart is, see the light orange at the bottom? Those are the number of new cases who have been diagnosed less than a year within the last year. That's growing, but it's only a very small percentage, somewhere between 2% and 5%, depending on where you're living. What's really growing are these other colors in this column. These are the longer term survivors. And that light, the teal or whatever color you call that, it was for people 15 years and higher, and that number is growing all the time. And a lot of those patients are not being seen in oncology anymore. They're being seen in primary care, and so we have a problem with who's going to identify and manage late effects if somebody's no longer being followed in oncology. And I'm not saying that they should be, but we need to realize that cancer care is more than just the care delivered by people in oncology, because these people have a long lifespan and they're alive for multiple issues to develop. Oops. Okay, so you've already answered the question. Great. So there's actually 15.5 million cancer survivors now, and that is growing to over 26 million over the next few years. That contrasts to when I basically started oncology in the 1970s, when we had 3 million survivors. So that's a success of our treatment and our early detection, that people are living longer like that. But we may know, or you may know already, the definition of a survivor is somebody who's been diagnosed and then through the balance of his or her life, from the time of diagnosis on. And then the National Cancer Institute also says family members, friends, and caregivers are also impacted by this experience and therefore included in the definition. So we know basically you can't talk to anybody who hasn't been touched by cancer. They've either had it, or a family member has had it, or a coworker, or what have you. So in many ways, we're all survivors. But when everybody's a survivor, it's hard to sort of pull back a little bit and say, what are the unique needs of survivors? There's a more refined definition of survivorship over the last 10 years. So you can be a survivor that's living cancer-free, or somebody who's living as a survivor but with cancer. The living cancer-free, you could be free of cancer for the remainder of your life, and if you're lucky enough, you could be not only cancer-free, but free of cancer. And in other words, not having any further problems. You go about your life, and it's a blip in the back. However, many people go on to have other problems from the cancer itself or its treatment. And so you still could live cancer-free, but then have residual problems. For example, myelolymphedema, or peripheral neuropathies from chemotherapy, or other kinds of things like that. You could also be living cancer-free, but then develop a late recurrence 15, 20 years later. Or you could develop another cancer because it's a disease of aging, and then you've been exposed to treatments. About 20% of new cancers are diagnosed in somebody who's had a previous cancer. So you want to get their history as well, because if they have, you want to understand what kind of cancer and what kind of treatment they've had with that. And then we know that we've made a lot of progress in helping people live longer even with cancer. And that could be intermittent periods of relapse and remission, relapse and remission. So people with non-Hodgkin's lymphoma or ovarian cancers, and some other cancers where we're starting to get more effective treatment even for metastatic disease. And then there's those who continuously live with their cancer, never going in remission, but the treatments keep it in check or at bay for a while, and people can live for years like that. And so that type of survivor is sort of caught in the middle. They're not cured, but they're not dying or at end of life yet either. And I think in the field of survivorship care, that group feels the most left out, and that we need to think about how we can address those needs. Many of those people don't consider themselves survivors, but technically they fall in that definition. There have been a good couple of papers looking at what makes a survivor a survivor. And so some of the survivorship attributes are listed here, and it doesn't have to be cancer. It could be Katrina or any of the other storms that we've experienced. It could be violence that you've experienced or any other things. But it's basically, if you perceive this to be a potentially deadly or a life-altering event, it's a dynamic process. So people aren't frozen in time. They change over time in relation to what they've been through. So somebody in that first year of cancer or the first year after that is very different than somebody who looks 10 years after in many ways. It's also a life changing experience, and it always involves uncertainty because nobody can guarantee whether the cancer is going to come back or how it's going to behave or how long you have to live or any number of those things. But most people find that there's some positive and negative aspects of it. So there's talking about the silver lining. And you often find out who your friends are or what's important or other kinds of things. But there's also negative aspects that may affect your function or your quality of life or your relationships or whatever. And on top of all that, it is still an individual experience, because this is happening to the individual and all they bring to who they are, their life experiences, and to where they are at the time that this is happening. So if you have had a history of child abuse, that's going to come up at a time when you're facing cancer, because it's going to trigger some of those other things. If you've had a different kind of childhood, those might not be the same issues. And so I often will try to ask patients about their own cancer history, but also family cancer history, because if they've lived through a parent or sibling or grandparent who died of cancer, you might want to understand what their perspectives are that may be very different than what's going on now. Like my grandmother was diagnosed in the early 80s with breast cancer, and treatments look very different than they do now. So I would, if I were my own patient, I would want to take that into account and sort of help people understand how things have changed. Now, about 2005, 2006, there was a seminal report and meeting called Lost in Transition. It's from cancer patient to survivor. And in essence, people felt like we were treating them and treating them, that they got treated and then it was all over, and then they had to figure it out themselves, regardless of whether they had any residual problems or not. So the 4 essential components have to do with prevention of recurrences or new cancers and other late effects, if it's possible, surveillance for those things, especially for long-term and late effects physically and psychosocially, interventions to prevent or mitigate those problems, and the last, which is where I think our system doesn't do as good a job as we can, is in the coordination of care between the specialists and primary care providers and with the patient and family. Because a lot of these people go on to do other they may move, they may have developed other problems over time, and so it's not just in the here and now we need to be thinking about. And many patients, if they don't have a primary care provider at time of diagnosis, one of the best survivorship things we can do for them is getting them hooked up at time of diagnosis with a primary care provider so that they can follow along and manage some of the other problems they may have, and also be a partner in sharing the care as time goes on. So I'm going to talk briefly about long-term and late effects, and this is called the road home. And if you could see the picture in detail, there's a lot of words in this map where the scars are, and the other maps are like fear and hope, etc. And it's like people, very few people experience cancer and don't have some effects of what they've been through, whether it's spiritually, psychologically, socially, or physically. And so one question I like to ask people, not only about who they are and where they live and what they do and what they like, but how has the cancer changed their life? Because it's a very view of who this person is and what they've lost or gained during this process. So we know that the long-term and late effects are a combination of things, not only the type of cancer the person has and the stage and the location, but also the type of treatment they receive, and also what their general health was before they were diagnosed with cancer. Because we know as a disease of aging, one of the issues is people have a lot of comorbid conditions, and in time we also make that worse, giving them more from our treatments. So this was a couple of studies I'm going to share with you. This is one that looked at the comorbid conditions in long-term survivors, looking at over 1,500 solid tumor patients with breast, prostate, colorectal cancer, or GYN survivors. Incredibly, they have an average of 5 comorbid conditions, 2 of which were developed after their diagnosis. And they're listed here as to what the most common is: hypertension, and you can read the list yourself. The higher burden is with older age, women with breast cancer, if the person's living alone, if they're overweight or obese, and if they're physically inactive. So you can a priori think about somebody you're working with as to whether they may be in a risk pool for more problems or not. So assessing the living situation and physical activity and sedentary behavior is going to be very important, as well as knowing what their BMI is. There were also a number of cross-sectional studies that the American Cancer Society did that looked at survivors at 2, 5, or 10 years out. That this is cross-sectional, not longitudinal. And what they found was that their unmet needs really didn't change a whole lot over time, so that they still had a number of unmet physical needs, financial and information needs about what's related to what, how to manage things, or what have you. Not surprisingly, there were differences between men and women, and also age differences between younger and older patients. Here was some other studies, and this was surprising to me, which is why I'm including it here, that about 1/3 of survivors experience symptoms after treatment that's equivalent to during treatment. And we all think it's going to get better over time, and it usually does, but there's a subgroup of patients who don't do as well, and we need to identify who they are so we can intervene earlier and aggressively to help manage that. The most common side effects that people report are things like fatigue, depression or mood disturbance, sleep disruption, pain, and cognitive limitations. So those should be on our normal assessments of patients to ask how they're doing with those things, because we can at least start with our basic assessment and think about interventions that are appropriate. Again, the higher risk patients were those who had more symptoms, who had poor overall quality of life, who were younger in age. This is one of the benefits of being older, is you seem to have experienced more things in your life, so you're more capable of handling another bump in the road depending on what you've gone through. So younger people don't have that same degree that we're seeing in older people in a lot of the studies that we're seeing. Lower socioeconomic status also is a big red flag for people who may have problems filling medications or adhering to them, or having access to resources that might help them. And then a larger number of comorbidities, as I just said. So some of you may be familiar with this quality of life model. The way I explain it to patients is that there's 4 buckets on physical, social, psychological, and spiritual well-being. So you may be having problems in one bucket, but your other buckets have boosted up so that you know that you're more spiritual or you have more social support. So they sort of counterbalance each other. If one isn't good but the others are, you may still feel like you have a decent quality of life. But we need to assess all of these so we can see what resources the patient has. So this is just a very high-level review of what we've learned about survivors over time, is that many people coming for follow-up visits have unmet needs after their treatment is over. And we're not doing as good a job as we can in assessing what those needs are and trying to meet them. A lot of those needs are informational and emotional. I work with breast cancer survivors, and it's interesting, at the end of treatment, a lot of times when we review in their survivorship care plan their diagnosis and pathology and staging and all those things, they start hearing it differently and understanding it differently and asking different questions like, should I be worried about my daughters, and should we have genetic testing and things like that that may not have come up immediately up front. There's very few survivors who have no problems, and they're the lucky few. And then there's the other problem is our research is not as strong as in pediatric cancers, where we don't have as many good longitudinal studies that are long-term of survivors to see how they do over time. So now I'm going to talk a little bit about what we do about those, and this is called picking up my pieces, and if you can't read it, some of the pieces say love, healing, hope, whisper, defiance, scarred, etc. And so again, this is one of those that's very powerful. But we're not able to deliver the survivorship care we need for a number of reasons. One is we're doing this in a healthcare system that, to be kind, is a little dysfunctional. We don't have really coordinated care. We're moving towards that with the oncology care model and the patient-centered home model, but it's still, we're in a shift from high volumes of care to adding value to quality of care, to the value proposition of just not how many people we see and treat, but how well we're doing with what their needs are, and doing that. That's going to be changing over time. The communication is not great. It's okay if you're in the same electronic health record system like Epic or Cerner, but otherwise a lot of communication between providers is very fragmented, and then between the providers and the patient themselves. And then research is that we need a lot more research being done. There's a lot of large data sets we can be asking more questions of, and we need more longitudinal studies of survivors over time to see what happens. Now I'm going to show you a video of something, and I want to talk about coordination of care for a minute, because this is a graphic to show you what happened with one patient who had a mass, a liver mass that was being found by the primary care provider and then being evaluated to show you how complex this can be in cancer.
And bear with us for just one moment.
Yeah,
now
we have to start from the beginning again, bring it all the way back. Okay, so this is the patient in the PCP, day 0, and follow it through. Thank you. Go back to the slide.
Absolutely.
I don't know about you, but when I saw that, I was blown away. That's just one patient. And think about all of us who have multiple patients and what they're going through and what we're going through to try and keep all this moving along. So what you saw was, for this one man, he had 12 clinicians. There were communicated 40 times with other clinicians and with the patient and wife 12 times. The patient underwent 5 procedures and had 11 office visits, none of them with his primary care provider. So the other thing that's really important is that we know who the primary care provider is and have them on record so they're keeping track of what's happening with their patient, because they frequently feel out of the loop with that. And this is another graphic that shows it as far as the cancer is concerned in a prettier cartoon, but not as dynamic, to show you the same kind of thing of how many people can be involved and why it's so important to be communicating with the patient and with the team to make sure that we're speaking the same language and sort of on the same page. Now, a lot of survivorship care is talking about the transition from end of treatment onto,
let's see,
Oops.
Whoops, lost.
Oh, there we go.
Let's see if we can get our cursor
Oh,
back.
here we go, here we go.
Okay.
So this darker red is the end of treatment in beginning the surveillance and follow-up time. But these kind of transitions occur from the time somebody thinks they have cancer to times when they know they have cancer and there's a treatment plan going on, so that there's different transitions across the cancer continuum. What we're talking about right now is that bright red rectangle from end of treatment to what's next, even though we know that this varies for different people over time. So the question is, if you know whether the Commission on Cancer 3.3 standard requires that all newly diagnosed patients, adult patients with cancer, should receive a survivorship care plan. Okay, so about half of you think that, well, great. So most of you agree that it's false, and that is true, because it's not required of somebody who's diagnosed with stage 4 cancer, but that doesn't mean it's not a good idea to do. It's just not required by the Commission on Cancer. So I'm going to go into a little bit of background about that, because that's, I think, what you're interested in. The Institute of Medicine 2005 Lost in Transition report recommended that patients receive what they call a survivorship care plan, which is 2 components, a treatment summary and a follow-up plan for survivors. but we call it a survivorship care plan as one document. It's intended to be delivered to patients and their primary care providers when patients have received curative intent treatment. The American College of Surgeons Commission on Cancer requires a survivorship care plan be given to that group of patients. However, one of the problems with adoption is it's time-consuming to create and deliver. There's not easy mechanisms to make that happen, and there's not good research data that says giving that makes a difference in outcomes for patients. However, we do know from less rigorous research that primary care providers and patients and families like them. So this is just a very big overview of the timeline, which was 2005, the IOM recommended it, and ASCO, the American Society of Clinical Oncology, developed some templates, but there was very little adoption of using them. So the Commission on Cancer in 2012 came up with the standard, figuring since we haven't done it on our own, maybe having it as a requirement would help people to do that. And again, ASCO, and something I was involved with, was creating simpler, cleaner, easier to fill out templates because they were taking too long and were too cumbersome. And then they got a lot of pushback that with the first recommendation was to do 100% in the first year, was realizing that nobody could really do that. And so they dialed down their recommendations. And again, people still had issues with that. And so there's been another clarification at the end of last year. So what ASCO's clinical expert statement on survivorship care planning said is that it discusses the importance of developing them and delivering this information both to the patient and primary care provider. And it has minimum data elements. So it's not to be the be-all, end-all. It's not giving the patient a notebook or 20-page plan. It's giving a 2 to 3 page summary that is a talking tool, a talking point with the patient to go through what they remember, what questions they have, and to find out what unmet needs they have, and to start that ongoing conversation. And then you can deliver extra materials if you need to. Some of the assumptions we made in making those recommendations are here. Basically, it's 2 parts, as I said, a treatment summary and a care plan. It's meant as a tool to facilitate communication and coordination of care. It's not something just to be handed off to the patient and checking a box. It doesn't replace discussions, but rather is an adjunct to those discussions, because we know that patients and families remember about 10% of what we tell them. So why wouldn't we give them something in writing? I don't know why we don't do that with every discussion when we see them, especially around those transitions in care, because most people don't hear and can't remember all the things that we're saying. It's not meant to replace the medical record. So if somebody has a recurrence, it's not meant to be where you go for the actual facts of the primary records and the patient's name. And that there are other groups of patients who need them, like patients living with advanced disease or intermittent relapsing remission kinds of cancers. But most of the work has been done in those who have received curative intent therapy. ASCO develops some standardized templates that people can use, and ASCO also has a compendium of survivorship materials if you're developing a program. This was the original or the revised recommendations from the COC, saying that starting this past January we would have 75% or greater of patients receiving care plans. But again, so many people had so many problems doing this that they backed off, and it's now capped at 50% or higher to do that. But they're adding a new standard, which is about survivorship care plan programming as a way to demonstrate that you're developing programs to meet the unmet needs of patients and having somebody who's accountable for all those things. So they announced these changes so that we know that it's 50% by the end of 2018. People are still struggling. And we know this is from older data, but we know that these numbers haven't really changed. These were in ASCO medical oncology practices, and they have a COPI standard that says chemotherapy treatment summary is completed within 3 months after chemotherapy ends. And you can see, even though all this work was going on about survivorship care plans, that it has still remained under 30% across the board. So we know it's a problem to do. And we're not achieving those goals. So when you're thinking about developing a system to develop and implement survivorship care plans, the questions you really need to ask is, who's going to complete and enter the diagnosing, staging, and I'm saying EPIC here, it's whatever your electronic health record system is. Who will estimate about when the patient's done and develop a tracking system for following those patients to know that they're due for a care plan, and who develops it and who delivers it and who makes sure that these are being done as far as tracking the numbers being completed and delivered. So it's not something that you hand off to one person and say, do this. And I've gotten so many calls from nurses at programs who are being handed this as a responsibility with no resources or support or sense that others have to be involved in doing this. And that's a real setup for failure. We did some different lean processes to look at how we were going to do this, and so we have at least 10 or 11 tumor groups, and we worked with each group to sort of walk through that and beginning implementation, and we've been doing this since 2014, and I can tell you we still have not met our numbers because we're still trying to refine the processes to get people to change their practice, which is probably one of the hardest things to do. We've developed a number of tip sheets to do this. We've cut down the complexity of doing this and how long it takes because clinicians told us that had to happen in order to keep doing this. And what we learned is that you can't just roll out a big program and hope that it's going to work. So you can start out with pilot programs with a group that's ready to take this on. So you look for your early adopters who say, yeah, we'll give it a try, and work out your wrinkles and bugs with that group before you roll it out to another group and then another, and that you get feedback as you go. So this is the typical PDSA cycles, and prepare to the glitches and fixing them along the way as you can go. So for example, we were 6 months into this when we got an upgrade that made everything we did before that not really relevant anymore. So you're always going to have things like that happen. So I think that what the change is going to be happening is nobody's saying don't do survivorship care plans, even though we've backed down on the number. But I want us to think about this from the time of diagnosis and realize that there's many transitions throughout the cancer experience, not just the end of treatment for those who end treatment. And that patients need written plans or notes that explain what's going on to them and their primary care provider. We also know that one size is not going to fit all. The literacy needs, the coping needs of individuals are going to make some want all the details and others not to see it at all. And that we need to think about how do we do this kind of care for patients who may be living with advanced cancers. The biggest take-home message is it's slow getting these changes in practice. And we've known that for years, but it's really frustrating that it takes this long to make things. When you think about how many upgrades your phone has experienced over years that keep getting successively better in what they do and how fast they do it, that it takes us this long to implement one thing clinically. It's hard. I also think that we need to think about moving it upstream to be including a written treatment plan for the patient and their primary care provider, because if they don't get those kind of things, this is really meant to be some type of a bookend, the beginning and the end of this process. But we also have to realize it's not giving a piece of paper out. It is thinking about where and how these people are going to get their care, who's going to deliver it, how are they going to get their unmet needs identified and delivered. And then we need to be able to have metrics to measure it. The one nice thing about the care plans is you can measure whether it's been developed and whether it's been delivered based on what's in the record. But there's other things we need to be thinking about as well. So I think of a treatment plan up front and a survivorship care plan at the end as sort of bookends to what we should be doing for patients. A treatment plan is not required by the Commission on Cancer, but why are we giving them this written information about who their care team is and what their diagnosis is? And the treatment plan at the end instead of at the beginning, and then you just adapt it for what's happened during time. So let's just ask the question now, is developing the survivorship care plan the only thing that's measured in standard 3.3? Good. I think you got that message. Thank you for listening. Because one of the problems has been is in the beginning, sorry about that, we are so focused on delivering this piece of paper and getting it signed off that we've lost that this is a process and it's ongoing. It's sort of like focusing on getting a consent form signed, but in fact, getting consent is an ongoing process because we have to reassess people's understanding and what have you. And so just in the last couple of minutes, I want to review for you some of the resources that are out there. If you haven't seen these, if you're struggling with developing a program or how to do survivorship care plans, ASCO has a whole survivorship compendium. This is just a brief snapshot, but you want to look at this. It has the templates in here, and it has other things about looking at how do you develop programs. The NCCN guidelines, this is an older page, but they are always updating this to identify the needs of survivors. George Washington has a program that is for primary care providers, and they have all these different modules. And I actually put the link and the note in this to in the care plan so that if primary care providers ever actually really looked at it, they might see this and want to use this. There's many other resources, and they have access to slides, right? Mm-hmm. So you'll have the slides, so you'll have all of these things, and that should work out fine. So my final thoughts about this is that we know that cancer incidence is still increasing, but at a much lower rate than it used to. So it's a very gradual incline. But the prevalence of number of people living with cancer is exponential. And that most of cancer care is actually delivered during the follow-up components of care, not actively during treatment or active end-of-life care. Most of it's that middle stuff. And if we don't rethink how we deliver follow-up care and figure out how to transition patients from cancer care to their primary care providers, we are not going to be able to manage the volume of patients that are coming through. So you really need to think about what's a discharge process over time for which kinds of patients. The UK does a risk stratified approach where they look at high and low risk need patients and figure out when do they go back to their primary care provider. The other is that survivorship care plans may be necessary, but it's not sufficient in addressing needs of survivors. And that we really are shifting some of our cancer care to thinking about what's after, including how do we encourage health promotion so that people don't get another cancer or that they manage with their side effects better. So being physically active, eating well, not smoking, limiting alcohol intake, using sunscreen, all those kind of things are as important to survivors as to anybody else. And that we need to think about our care delivery systems because the way we're doing it now is not adequate and it will not be sustainable over time as the number of survivors grow. So I think at this point what we want to do is open it up for questions and whatever else we can do in the last few minutes of the program.
All right, great. So you can just go ahead and text in your questions using the same poll everywhere technique you've used to answer questions. You can also use if you're viewing via Zoom, you can go ahead and use the box there to ask that question. And you can also email those questions to unccn@unc.edu.
So can everybody see this question?
They can see that, absolutely.
So we spoke about that for many cancers, patients are living longer and brings the issues of secondary malignancies up, particularly in hematologic malignancies such as chronic lymphocytic leukemia. Do we have protocols for cancer screenings for these survivors? In the case of CLL with new novel agents, these patients can now live decades. I see this as a big care gap. So this is a gap in our research. So in much of the surveillance that we do, it's no different than the general population. I'm sorry.
Oh, quite all right. Yeah, there you go.
Okay, sorry. And so what we recommend, and the NCCN guidelines will spell out under their surveillance plans about what patients should get for their cancer. But when I see women with breast cancer, I'm always asking about their colon cancer screening because and their heart disease management because they're at higher risk if they live longer from that cancer to develop these other problems. And for men, you would do whatever is the evidence-based recommended screening, which is mostly around colon cancer screening. So anybody with an existing cancer who's doing well, you should be still asking the questions about their surveillance that are the general population screening. We don't, unless it's a very specific circumstance, we really don't have special surveillance guidelines for other cancers in this population.
All right, thank you for that question. Please go ahead and keep submitting those questions, and we'll get to as many as we can. How do you track these patients at UNC to know when the care plan is due?
Good question, and if you have an answer to that, I hope you post it too. That is an incredible challenge. We keep revising the way we're doing it and hoping to come up with a better way. A lot of systems use their tumor registrars, that when they abstract the cases, they get put on the list or shared with whoever's overseeing this. We are right now creating a shared list in Epic so that when the tumor registrar does the analytic case, they're entering them in by tumor groups so that the tumor groups can then look in this list and see who's eligible and when they're coming in to get the care plan. We are still developing it, so we don't have our pilot data to tell you whether that's going to work. I'm sure other people have done other things, and that's where if you do, you don't have to post a question. If you have experience doing this that works, we all want to know about it.
Right. Do you have any tools to evaluate outcomes?
So there's different kinds of outcomes based on the stakeholder you're interested. There's the healthcare system, there's the providers, there's the patient and family. Most of the studies and care plans have been done with patients and their providers. There's a high degree of satisfaction of liking them, but in tracking other kinds of outcomes, like does it change adherence to surveillance, or is it cheaper when patients get the care plan than when they don't? We don't have good data on those kinds of outcomes yet.
All right. In your experience, who usually discusses the care plan with the patient?
Well, I think it's most appropriately done by an APP or a nurse navigator, but oncology nurses, nurse navigators, nurse practitioners, physician assistants. Sometimes physicians do them, but they tend not to want to do them or like doing them. But if they do, reward them for that and encourage them to keep it up. But I think we are really good around patient education, and this gives us an opportunity to assess how they're doing and to revisit this periodically with them. So I think I like giving them out because it's a chance to check in with me, with the patient, about the patient's understanding of what they had and what they went through, and that there's a lot of unresolved questions or things that come up in this safe space, talk about it, that may not come in when they think they're coming in just to see if their cancer's recurred. A lot of these follow-up visits feel like it's just about surveillance for a recurrence, when it really is meant to be more than that for patients.
Have you given consideration to research patient long-term follow-up and whether they should or could come through the NP survivorship clinic rather than see, and we're missing the end of that question, unfortunately.
That's okay. Well, one is it's hard to think you're going to see long-term outcome differences when you can't find short-term outcome differences. And that's one thing about the care plans, but the other you're referring to here is the model of care. And whether people just go to an APP clinic for follow-up is one thing, but there's many models of care. The shared care where you do it together, like I've heard of one GYN oncology group that alternates with the gynecologist so that every other visit's with the gynecologist so that they're more comfortable when it's time to discharge a patient. APP clinics, I think, are natural because it frees up the physicians to see newly diagnosed patients for treatment planning and for those with recurrent disease where it's more complex care. So there's a lot of opportunities with this, but we don't have good data to say when one situation is the best for certain types of patients or settings or not. So it's really a crapshoot as to how we're doing it right now.
So one can imagine that not all SCPs are created equal, and that over time we're going to get a much better understanding of where the efficacy really comes from.
Yeah, if there is efficacy.
If there is efficacy, yes, at all.
And I'm sure that if it was easy to do, we wouldn't have spent all these years discussing it and fighting over who's going to do it and how. If it was easy to do, we wouldn't have thought twice about it. We do a discharge note and summary for the patient and for their providers That's never really been studied to see what difference that makes. But because it's built into what we do, it's normal. Right. We do an operative note. You know, that's just standard of care. This became complex because it was time consuming and difficult to do, that it made us back up and saying, well, do we want to spend all these resources doing something that may or may not be effective? And then it led us down a whole different path than other care standards have been.
Do you have a delegated clinical coordinator for a survivorship program at UNC who tracks patients or calls the patients?
No, not really. And we don't. So some people have thought about survivorship care as something that you carve off and you give to somebody else to do. Most patients don't want that. Most patients want to be seen in their tumor group or the providers that are seeing them. So I recommend that it depends on the setting how to do it. So for example, if you're being seen in an academic center, you may be followed in a breast program. That's fine, but maybe you're shifting from seeing the medical oncologist to the nurse practitioner. Or you're seeing the ABP 2 out of every 3 visits. So I don't think it has to be black and white and rigid in depending on the type of patients you're seeing and the type of setting that you're having. And it should be integrated into your follow-up care. I don't think we should be separating it out as this survivorship care as if it's special. It is the care we should be delivering to people when their treatment ends. Just like you get post-op visits after your surgery's over to see how people are doing and recovering and returning to function, that just should be part of the survivorship care we deliver when we take care of people who have cancer.
Do we know if nationally there is more success with meeting the standard of survivors that go through a survivorship clinic or seeing a clinician in office?
No, there is not. And that's where we need more health systems research to look at these kind of metrics. We don't have good metrics to measure this, and we haven't had good studies to do that. So unfortunately, you can't turn to the evidence to say we should be doing it this way or that way. You should be looking at what's been done and then deciding as a team or as a group, with the type of patients you see and the type of practice you have, what makes the most sense for you.
And with this COC backing off from 75% to 50%, what kind of decision making goes into what is the 50% who's receiving these SCPs and what's the 50% that's not, if you're making that or hopefully going above that?
I don't think the 50% is meant to be intentional. It's just meant to lower the bar so that people aren't freaking out about whether they should remain in the Commission on Cancer or not.
Okay.
And I think it's a crapshoot as to who's in what side of that 50%.
Okay. All right. We have just another moment if you want to text in that last question, and then we'll move on and talk about upcoming programs. All right. Yeah, so we want to thank the generous support of the North Carolina General Assembly for the University Cancer Research Fund, known as UCRF around here, and the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Mary King, Veneranda Obore, and John Powell, for all the hard work they do to make this lecture and every lecture possible. Of course, we want to thank you, Dr. Mayer, for being here today. Thank you so much. Upcoming, we've got a medical and surgical oncology lecture on August 22nd at noon, recent advances on the gut microbiome and cancer therapy with Dr. Keku. And then we have on September 12th at noon, RN and Allied Health lecture, Immunotherapy 101 with Dr. Armistead. So we hope you'll join us for both of those. And of course, about a month after the live lecture, you can go anytime, day or night, and watch the lecture, take a brief test, and receive credit for those up to a year after the lecture. And having mentioned that, our self-paced online courses, we've got 2 that are about to become available soon, and those are using biomarkers to plan adjuvant therapy in breast cancer and breast imaging technologies, cancer detection, and personalized medicine. Those with Dr. Carey and Dr. Kuzmiak, so we hope that you'll find those in September and have an opportunity to watch those and receive credit for those if you have not already in the live format. And with that, thank you for participating. Visit our website, unccn.org, for lots of information about previous lectures, upcoming lectures, all sorts of other events. Dr. Meir, thank you so much. It was a pleasure to have you here today.
Thanks. Thank you, everybody, for sticking it out.
We look forward to seeing you next time. Thank you.